My name's Daryl O'Donnell. I'm the CEO at the Australian Federation of AIDS Organisations. I'm really delighted to be hosting this session this afternoon. Can I begin by acknowledging Aboriginal people as the traditional custodians of the lands that we're meeting on all around Australia. For me, that's the Gadigal lands of the Eora Nation. And I pay my respects to elders past and present, and particularly to welcome any Aboriginal people who are joining us for today's webinar. We had our first webinar on the science of COVID-19 and on the public health response to COVID-19 about a month ago, which may as well have been years ago, I think, in terms of just how fast not only the pandemic is moving, but actually the response to the pandemic and the learning about this virus is moving. And so we wanted to regroup. We wanted to bring you back together to hear from the very best about the science and about the public health response to COVID-19. And we've got two presenters, Dr Rob Grenfell from the CSIRO and Dr Damien Brown from the Doherty Institute, who'll walk us through that science. And I'm very grateful to have both of them here. The way that we're going to run today is to use the chat function. So everyone, if you have a look at your chat button down the bottom, that will allow you to put comments in. You can share those comments with everyone on the group. If you have questions at any stage, please add them to the chat box, and we'll keep an eye on that. And we'll pitch those questions to Rob and to Damien at the end of their presentations, and also during the discussion at the end. And also, if you just want to introduce yourself and tell us who you are and why you've joined, tell us a bit about your organisation, tell us you might want to share some resources with us. You might just want to make a comment on some of the points of discussion. So please feel free to use the chat function to make this an interactive experience. Let's kick off. We've got about an hour, and we want to make sure that there's plenty of time, not only to hear from Damien and Rob, but also to have some discussion and to put forward some questions. So to begin us off this afternoon, can I introduce Damien Brown? So Damien's a clinician and a public health registrar working with the Doherty Institute. And I think it's no underestimate, it's no understatement to say that the Doherty Institute really is at the heart of global leadership in the science and response to COVID-19. And we're really pleased to have Damien to join us. I think most of us will be aware that the Australian government is making decisions about Australia's response to COVID-19 based on modelling, the very best modelling that we can put together. And that modelling comes to the Australian government and to chief medical officers from the Doherty Institute. So we particularly wanted to hear from Damien about that modelling, about what that tells us, and what the assumptions are within it. And so really glad to have you here, Damien. Thank you. Take us away.
Thank you. Hi everyone. Just bear with me. I've got a PowerPoint slideshow. I'm just going to try and get this up and running on Zoom. So hopefully this. All right. Can everyone see that? Yeah, great. So I'm just going to talk you through briefly about 10, 15 minutes, the modelling I've been involved with. So this has all been with the Doherty Institute in Melbourne. And just by way of sort of semi-apology and caution, I'm not an expert modeller. My background, I'm a clinician. I've spent much of the last decade with flying doctors and Médecins Sans Frontières as a clinician and public health advisor. And have only recently, over the last month or so, been brought into the Doherty to work with the modelling group as a sort of a clinical collaborator, a clinical advisor. So the modelling I'm going to talk about, this is the real sort of big piece of modelling that the federal government used and presented about a week or two ago. This is our Chief Medical Officer, Brennan Murphy, and him and Scott Morrison released released this formally a couple of weeks ago. And this was all overseen by my boss, Professor Jodie McVernon down here, who's the head of epidemiology at Doherty. And just a little plug, and for point of interest, she'll be the studio guest on Q&A tonight. So I'd highly recommend tuning in. She'll have a lot of new insights. So just very basically, modelling. it's a tool to help think about a problem in a quantitative way using a framework. Invariably, there's evidence lacking in some domains, so assumptions need to be made. And the modelling really is only as good as what you feed into it and the frameworks and assumptions you set up. So there's a lot of bad modelling out there, is the caution. And there's this sort of adage in the modelling world, all models are wrong, but some are very useful. And obviously, everyone's extremely mindful of undercalling versus overcalling, you know, the outputs, dire consequences both on a health and economic front if people get this wrong. So the big questions really that needed to be addressed up front was, how bad could this get? What's the likely scenario? What's the best case scenario? What'll be needed in terms of resources, and particularly ICU resources were the major sort of anticipated bottleneck initially, and how could we mitigate this? So the things we needed to look at first and the assumptions that needed to be made really around transmission dynamics, and that sort of alludes to, I think we'll come back to this in the Q&A section, I'm sure, but how exactly does this spread? The time periods, and these are quite important. The major issue here is the period of communicability. So there's the disease period where people are symptomatic. We made the assumption that based on some data that people are also probably able to transmit the disease for about 48 hours before they have symptoms. And there's a period once symptoms have resolved as well that people are still infectious. And then this very important variable you probably would have heard of in the media called the R0, which is the reproductive number. And that essentially is how many people get infected from each case. So if you've got the infection, how many people are you likely to give it on to? If the number's 1, then the numbers of infected people will stay the same. You know, as one recovers, another one gets infected. More than 1, and you get exponential growth. Less than 1, and you start to reduce the epidemic, which is where we're at now, which we'll come back to. The other thing where a lot of assumptions need to be made is the spectrum of disease severity. And we talk about a disease pyramid. At the top, you've got your sort of ICU patients that are obviously very visible, you know, incredibly unwell people. And the data between countries, particularly when we were doing this modelling, was quite different and emerging very quickly. So our assumptions were in the range of about 5% of symptomatic patients would need ICU, about 15% of patients would need hospital admission. The vast majority, around 80%, would have a mild illness. And then there's this huge unknown of the burden of asymptomatic cases. And these are people that can still spread, but that we're not finding. And then obviously you need to determine plausible ranges around these. There's a huge age variation in terms of the severity. You know, older patients are disproportionately affected. The effects of other illnesses, which we didn't model for. So we know that people with severe respiratory disease, diabetes, cardiovascular disease have worse outcomes. And the role of children, which is evolving and obviously has been an area of debate in terms of schools and their role and closures. So these are some of the assumptions that we used. Just brief summary. So incubation period of about 5 days. So that's between getting exposed and actually developing the illness. A doubling time of the epidemic of 6 days. The R0 that I alluded to before of between 2 and 3, around 2.5. And this is quite important as well, the infectious period. So people that have infections will be infectious or able to transmit for about 10 days. And this is quite an ugly table, but look, in summary, it's just to show the huge, huge differences in outcomes in terms of age. So if you look at the 80+ year age group, the odds of them requiring ICU, or the chances, are around 10 to 20%. That's of all infected people, we think. And the odds of, or the chances of ending up in hospital are 30 to 65%. So really, really significant burden. And you contrast that with younger age groups and it's well less than 1%. The other thing that's quite a significant factor is that the mean admission for ICU patients is 10 days. So once someone requires ICU admission, you know, it's not just a couple of nights, it's on average 10 days. So that has a huge impact in terms of the resource allocation. The next thing we had to think about systematically is just how this actually affects hospital capacity. So accounting for the existing capacity in Australia, how it can be increased, and then how patients move through the system. So not getting into too much detail, but obviously most patients with no or mild symptoms will end up going through the GP ED system or these COVID-19 clinics that are opening up. And for the severe end of the spectrum, there's a range of bottlenecks that might sort of hide patients from the system. So if patients aren't able to be triaged and overwhelmed EDs, then you're not going to be aware that there's this burden of severe disease. So we took that into account as well. And then the effect of interventions, isolation and quarantine of contacts we modelled for as a baseline, and then the impact of physical distancing measures. So basically what we've got in place now. And there's a lot of assumptions of this as well, because it depends on compliance, and human behaviour is one of the hardest things, obviously, to kind of predict or model for. So we assumed 80% of about an 80% compliance rate with what we've got in place now. And a lot of this was extrapolated from influenza data. Most of the team had been involved in influenza pandemic modelling over the recent decade. So this had to be extrapolated from that, and emerging data as well, obviously. This is just a very rough kind of concept diagram of how that works. This is where the mathematicians get stuck in. And essentially, it uses what we call an SEIR paradigm. So S is the susceptible, the number of susceptibles, which initially in an outbreak like this, where none of us have any immunity, you consider that the entire population is susceptible. Then we move through the proportion of people who are exposed, different, as a sort of different proportions that are exposed to different degrees. Then people are infected, and then people are recovered. And then obviously coming off that, there's people needing medical care, and then there's sub-branches, so people put in quarantine and how they progress through these. And this is where the mathematicians get stuck in and run these through numerous simulations, looking at sort of plausible ranges, adding in the effects of random chance, confidence intervals. And that's where it quite quickly gets beyond me. But the output is the famous sort of curve and the flattening the curve images that we've all become familiar with in the last month or so. So the findings, really the main thing we wanted to model for was the ICU demands and how this was going to impact our health system. So this top graph is the unmitigated scenario. So assuming we stood back and did nothing and just let this thing rip through the community, these are, the red is the median, so the sort of median scenario. Australian healthcare, the ICU capacity, so these are daily demands for ICU beds per millions of population. The existing capacity is around here between 0 and 500. It's around 200, I think 150. So you can see that even in the best case scenario, if we did nothing, it'd be overwhelmed by orders of magnitude. The next sort of scenario to look at was the quarantine and isolation. So that's identifying most sick patients, so more than 90% of symptomatic patients, isolating them, tracing their contacts and quarantining them. And you can see as well, obviously that flattens the curve. So your peak occurs much later. It's a lower peak, lower absolute numbers. But again, considering that our capacity is somewhere between 0 and 500, we're still significantly overwhelming what we could cope with in terms of ICU capacity. So this is just a repeat of that graph again, the quarantine and isolation at the top. The next two are overlaying the effect of social distancing measures. And it's very hard to sort of separate, what school closures versus closing bars versus closing workplaces will do. So we just assumed, we modeled for two scenarios. One is that social distancing leads to a further reduction of 25% in transmission. The other one was a 33% reduction in transmission. And really, you consider 25%, you're still overwhelming. All these lines are still significantly over where our capacity is. And not until you get to about a 33% reduction, so this is over and above quarantine and isolation, that you get within sort of plausible sort of coping capacity of our healthcare system. And just for point of reference, the modelling last week showed that we're actually at about 50% reduction. So our R naught's actually at 0.5. So to skip ahead, we're actually doing far better than the modelling showed in the best case scenario. So that's extremely encouraging. very ugly tables, but in summary, this was just to show that we try to take into account the percentage in terms of peak exceedance of demand. So this is the percentage that we'd exceed the demands, exceed the capacity by. And you can see here at baseline, so not doing much, you're talking 200, 300, 400% exceedance of capacity. If you increase ICU capacity by 5 times, you're getting into the realms of being able to cope. This, just as an interesting aside, the COVID-19 clinics show that things seem to be worse. This is overlaid on a 5 times ICU capacity, but that's just to really show that we're finding with those COVID-19 clinics in an overwhelmed system, you'd be finding more patients that otherwise would not make it potentially into EDs and overwhelmed GPs. This is a very similar thing, but just to show that the duration of excess demand. So in the unmitigated scenario, you're talking 30, 40, 50 weeks that we would have been in excess, that the ICUs would have been overwhelmed for. So, I mean, significant periods, not a couple of weeks. So in conclusion, what this modelling showed was that an unmitigated epidemic would dramatically exceed the capacity by many orders of magnitude over an extremely prolonged period. That using case isolation and contact quarantine alone would reduce transmission, so would flatten the curve, but would still overwhelm the health capacity quite significantly. And flattening the curve would produce a more prolonged epidemic, but lower overall numbers and a lower peak incidence. The COVID-19 clinics would reveal a higher level of unmet need that we would have missed before. And in summary, the case isolation and contact quarantine alone would have been insufficient within any plausibly achievable expansion of our health systems. So essentially the physical distancing measures that we're now living under or living with are essential. And a transmission reduction of 33% revealed that a treatment of all cases would be achievable in most simulations if we increased our ICU capacity 3 to 5-fold, which is significant. Just as an aside, Victoria's aim was to increase it by 8-fold within the next month or so. And I think the national aim was about 4-fold, 4 to 5-fold. Our findings are consistent with plausible other global models, which showed that in high-income countries, we'd expect to outstrip supply of healthcare by a factor of about 7. And then obviously limitations that we're quite aware of, the assumptions are evolving as data is emerging. There's ongoing uncertainties about the true disease pyramid, so particularly the number of asymptomatics out there. And we assume throughout this that at baseline, half of all bed capacity in Australia would be available for patients with COVID, which is quite an assumption. But just as an interesting aside on bed capacity, just anecdotally, I worked in the Northern Territory about a month ago for the last time, and the last time for a few weeks, and just friends that are working in emergency departments in Melbourne. The number of attendances is significantly lower than it would normally be for other causes. One, because people are avoiding emergency departments and hospitals because they're worried about getting infected there, and obviously because people are out and about far less. There's less trauma, there's less road accidents, and in fact less other respiratory infections. And importantly, we didn't consider the impact of healthcare workers getting fatigued, unwell themselves, needing to quarantine, burning out. So in a total summary, the model indicated that a combination of case-targeted and widespread social distancing measures will need to be applied over an extended period to reduce the rate of epidemic growth. And that's what we've now seen, fortunately, that we are now curbing this as a consequence of this. And I had some other points I wanted to raise, but I think I'll just leave that for the discussion later, Daryl.
That's great. Thank you so much, Damien. Really appreciate that. We've got one question, a technical question, which is both for Damien and for Rob, which is regarding just sharing of slides. Are you both happy to have your slide sets shared following this call?
Absolutely, yeah.
Rob, okay for you?
Yeah. Mine are mainly pictures, as you know, Daryl. So,
right. So, and in fact, we're also recording this session and we'll be able to share that. So we'll upload that to Orfeo's COVID-19 landing page for anyone who wants to access the webinar afterwards. And that'll include the slides. So, so Damien, thank you very much. I do want to come back to some of the follow-up points, including so the modelling is fantastic for telling us how to actually respond, or pointing us in directions that would allow us to respond without the health system being overwhelmed. And then in the discussion, it'd be great to come back to questions of eradication as a strategy for Australia, to herd immunity as a strategy for Australia, and so we'll save those for discussion. Let's kick in now to hear from Dr Rob Grenfell from the CSIRO, Head of Health and Biosecurity at the CSIRO, and my colleague on the board of the Global Health Alliance. Great to have you here, Rob, and to walk us through where are we up to and what are the prospects for therapeutics, for diagnostics, and for a vaccine for COVID-19.
Excellent, no worries, Daryl. Now I'll find my right presentation and share it. And away we go. Slideshow, come on, excellent. So this is a picture of the virus itself. As you can see, the little crown that's around it, which is the corona there, the protein spikes you hear a lot about. This is an electron microscope picture of the virus that was grown from the Doherty and then replicated down at our laboratory in Geelong at the high containment facility that we've actually got. Quite pretty, as most of us would say, but also very dangerous. So coronaviruses, just to go back to what they are, the coronavirus is well known to us as humans, but two of its real nasty friends are SARS and MERS. And if you really think about just the basic sort of thing, SARS, as it appeared, had a fatality rate of 15 to 25%, depending which country it was in. It was easy to find the cases because people got sick, they were hospitalised, and what actually happened was it just shut down by containment. MERS was worse, 35 to 45% fatality rate. So again, as it came from the Middle East, it spreads to South Korea, where it unfortunately killed, as SARS did, a lot of healthcare workers because they were exposed to the virus as it fitted. The COVID-19's, as Damien so well put about what we do know about its fatality rate and also its spread rate, seems to be where nature has in fact actually had a bit of a test and got it right. Now it tends to do this with outbreak diseases. This is how nature works. We have a crack at something, it works or it doesn't work, and then we have another go at something else. And COVID-19 seems to almost like it's like the perfect pandemic virus at the moment. It's behaving in such a manner, if you think about it. So where did these come from? SARS came from bats, spread to civet cats, and then to humans. MERS came from bats, went to dromedary camels, and then went to humans. COVID-19 came from bats, and we don't know where it came from. We do actually know that there were variations of the coronavirus circulating in southern China years to months before this outbreak, because colleagues of mine that work for the Echo Health and also Trevor Drew, who works with us in Geelong, had been certainly doing some CSIRO surveys in the environment. So these things were there. And even in the Australian wildlife, some of the surveys that we've done on time, we've found coronaviruses and filoviruses in some of our wildlife. So there's question one is, why aren't we looking harder? And that's the same thing about most things in research, is we only pay for certain things in research and not always necessarily what's a high priority. So running through this one, and this one came from the a talk I was at with the CDC in the US about looking and understanding about this. And Damien's diagram was much simpler than this one, but there's so many things we don't know. This thing here in the grey one at the end is reinfection, 1 to 14%. We just don't know because we don't understand the antibody tests at this stage. And for those of you who were around in the early days of HIV, when we started with Western blot and then moved on to others, and now the definitive thing is viral counts. That's where we find ourselves with COVID-19. Is it still the PCR? Are you shedding the virus? That's really all we're left with. That we do know. That's a certainty, as opposed to what do your IgGs or A's or even IgMs actually mean. We don't have those specific answers about where they are. And I guess in the sense of actually where you're infectious and the severity about where you're going. And we saw in Boris Johnson the progression. Do not say when you contract this disease at day 10 that you think you've got over it, because that's actually the turning point. And the mechanism for that seems to be a cytokine storm where your body decides it's going to kill itself. And that essentially starts on your lungs. So that'll be a relevant thing to remember about your lungs and lung disease when I get down to the models that we've got for the vaccine that we're actually working on. This one here is just a recent one from the federal government, and you know, Damien and Jody's team, I mean, all with that, and I was certainly at the beginning of this in direct contact with Jody on a number of occasions, working out where can CSIRO help with what's going on. And the other thing that, of course, is our pet dislike, which Damien was very polite about, is armchair epidemiologists. They are driving us crazy, right? You know, epidemiology as a public health doc is what I studied. Epidemics is what I studied, and as you saw with Damien's magnificent presentation, he knows this stuff. But you know, the commentators in the press, the commentators all over the place, and in fact, I even have to deal with armchair epidemiologists in my own organisation that are forever trying to tell me that they understand the epidemic of infections. Let me believe it. I think what Damien presented to you is state-of-the-art epidemic modelling. Now, what you can see flattening the curve, the most important thing to remember is the number of cases are still going up. Now, Australians can't understand that. Most people didn't go past year 7 mathematics. And so this has been one of the hardest things to communicate. Just because the rates decrease, we've still got new cases, all right? It's still going up. It hasn't disappeared. So I put this is again, Jody and team's work about the uncontrolled in a simplistic way of looking at the differences in how you do it. The scary part is this, right? We've gone from a peak and now we've stretched this because we've actually gone to quarantine, isolation and social distance. And you see, this is more and more weeks. And I think those are the sobering words about what it means about how long is this going to go on for. And I like to talk about the foolish idea of herd immunity. UK tried it for a short time until the Imperial College and others tried to put heat on the government to get some sense in the UK. America is just, I don't know what Trump is trying to do with his people, but it's certainly not humane. What happened in Italy and Spain, what happened in Wuhan was this: the infection hit and it went slap. And it went into the highest of uncontrolled levels that you've got. And Sweden, for instance, of course, with their experiment, which is now proven to be also just not possible, because, you know, reflecting on what Damien said, human behaviour is extremely hard to measure. It's a really extremely hard variable. And even in a well-controlled community like Sweden, where they reckon they put their elders and vulnerable people away, they clearly didn't. And they're now actually seeing an increasing death rate, an increasing case. This is not a disease to do herd immunity with, all right? That's the lesson that we've been shown many times. Flattening the curve is really saving your health system and meaning that more and more people can get access to the healthcare they need to live. That's all we're trying to do. And those people are very important people to all of us. They may be your grandparents, they may be your parents, they may in fact actually be friends and relatives who are suffering from serious diseases that are affecting their immune system. Now, flatten the curve. We've got this blue one that's coming up, and this is the one that I know that Jody and Damien and team are actually going to be trying to work out what does it mean. This sort of curving is modelled on influenza. So that's one we do know. And we know that with swine flu, we had 3 peaks. And the second was particularly challenging. The third wasn't actually that nice either. With Spanish flu, the third one was the worst. It killed more people than the first and second. But Australia was able to quarantine itself for a year with the Spanish flu. So that gives you an idea of how we actually were even doing epidemic modelling then. This second resurgence, now that we've successfully flattened these, has really thrown the modelling way out on this one. And I think we could talk about the scenarios about what the new normal may be over that period of time as to whether we will get a second curve or not. That second curve, in a sense, think of it like what's happened at Burnie. 1 infected person and now 5,000 people in enforced quarantine because of the exponential rate that these things can get out of hand. So this could be anywhere in pockets in Australia where we might find cases breaking through and doing this. So the other one from our colleagues at the Grattan as to what they put about ICU bed, and another way of putting what Damien put with regards to doubling cases. So that's your explosive growth. You're way out of intensive care, which is what we're seeing in New York, sadly, that they cannot cope with what they've got. but this is the sobering part, doubling every 10 days, we're still looking at the potential of actually going over our ICU bed. So the idea of actually almost total suppression of the virus is really the target we need, because in the back of our minds is that this could get away, and this could in fact actually rapidly start to move in taking our intensive care beds. And that's largely what the paper from the Grattan Institute was talking about. This one came from The Guardian with, there's four scenarios here, and this one, I pulled out the one that actually looks like it's more likely with the persistence. And as we talk about this nasty virus as to how it's behaving, get that initial peak, and then you get this idea that it's still around and doing it. You might get blips and takeoffs. For countries like ours, which will have limited exposure to the general population, we may find that there's sharper peaks that actually occur on this period. So simplistically looking at what may happen, this is starting to be more likely than any of the other scenarios of eradication. So what can we do about it? There's really only three things you can do for a virus. The ultimate is a vaccine, and a vaccine, essentially, if enough people have that vaccine, you will develop an immunity for the virus to actually not find a favourable host. But this is very complex, and look at this, 10 to 20 years. And so you've heard a lot of bold and brash claims coming out of a lot of researchers over the last things, and I will come through that. The cost is astronomical, 2.5 billion. Therapeutics and drugs, and again, we're working with Doherty on a number of these, of actually looking at repurposing, because you've either got drugs that stop you getting it, so prophylactics, you've got drugs that actually will treat it and cure you, you've got drugs that decrease the inflammation, but what do? We can look for inflammation. There's lots of drugs we've got that work in the cancer area that could in fact be repurposed to decrease the lung inflammation. So you're hospitalised, but you don't get ventilated because it actually decreases the cytokine storm or decreases the inflammatory response. That sounds pretty good if it works. The other one is the repurposing of drugs, and you've probably heard a lot about this drug called hydroxychloroquine, which thankfully there are some well-conducted studies being done, not studies that are being done by the White House, which are not a way of doing studies, as we've seen for many times with many infectious diseases. So I think in the sense, therapeutics, 10 to 20 years, up to $1 billion to get it out. The diagnostics is the other one that we need. And we need diagnostics for a number of reasons. The PCR is the gold standard, but at the moment the tests are done in laboratories and they require some degree of reagents and batching. The next point we need is what I would call interlinked and self-care testing, which again in the HIV space has been a wonderful introduction to in fact finding cases and assisting in case management. Point of care testing has come a long way from when I started medicine back 30 years ago. They were only starting to get people to look at blood glucose monitoring. Okay, that's point of care testing. And now a child can be at primary school and their mother can be looking at their glucose levels on their smartphone to see how that's being managed. That's what we're talking about. So some of the devices that are actually in late stage production here in Australia, low cost, 15 to 30 minute results. They're still being validated, obviously, but the other is they're connected to software in the devices that then sends those results to the cloud, which means we can do surveillance through point of care testing. This is what the new normal will sort of look like to find those epidemics. But the challenge for us now is to get those tests into the market. And the Doherty is certainly working with 2 of those, and we're working on a couple of others as well of how to actually move those forward. So let's go back to vaccine, because that's really the best part. If we look at the basic research, to get to the idea of actually identifying targets and characterising viruses generally takes 4 to 6 years. With the COVID-19, we're lucky. We'd played around with MERS and SARS, so we actually already had an understanding about some of the surfaces and the genome of the virus, the proteins on its surface, and also the way that it behaved, which was actually good. The other one, as we moved into this, my team in Geelong had already been working on ferret models with SARS, which gave us an opportunity to retest another model. So why the ferret? The ferret shares a receptor on its lung lining cells that we have as humans called the ACE2 receptor. So if we can get a vaccine that generates something to block that receptor, we then in fact actually will have a vaccine that could potentially block the infection in humans. But look at this, 1 to 5 years generally to do preclinical. And when I talk about the speed we've been doing these things in, you'll go, whoa. And then clinical development. So phase 1, 2, and 3. 5 to 7 years, and then the hard yards of actually producing enough vaccine for the world, because the world needs this, and this is going to be an equity disaster that we're really going to need to look at. Who gets it? When do they get it? How do they get it? When I was a junior doc in the emergency departments, HIV obviously was still misunderstood. We actually didn't. We were living in fear of blood exposure in emergency departments. We were doing complete and utter exclusion from blood exposure. But hepatitis B was the one that we were worried about the most, because we'd already seen elderly colleagues die of liver failure in Australia from hepatitis B from the exposure. The first Hep B vaccine turned up, and we were offered that. They said, we can't guarantee that it's free of HIV, but it probably is because of the way it's been treated. And it was $150 a dose, which the hospital covered. We all lined up and had it. Why? Because if you work in an emergency department as a junior doctor, blood is a friend in a sense, because it's just, that's your work site. And I guess in one sense, the idea of actually getting hepatitis B, the rollout of that started with a very expensive vaccine, then the recombinant one came through, mass produced, but we still introduced that for positive women who, and to protect their children. But now it's actually incorporated into the childhood immunisation schedule. So you sort of get an idea that these things take a long time. I'm talking 30 years for us to have Hep B vaccination as a normal component to what we're doing. And that required a lot of work with industry to manufacture it. So a busy slide, but just to really explain what happened. So yay, Doherty, you grew it, and first out of China to grow it. And we got it within a couple of days down to our centre in Geelong. And then came the time of actually growing it at what we call industrial quantities, so that we can start to test it on a range of things. And then sequencing, and our team's been doing a lot of sequencing on the global genome of that, and published a paper today, believe it or not, I think it's in PLOS Med. But that's on the clades of the virus. There's arguments between 3 to 5, but what are the types? And we tend to be the Wuhan type here in Australia. But RNA viruses are pretty sloppy, right? They drop a lot of their genome when they replicate. So that is, they mutate. What is good is that it doesn't appear to alter the protein on the surface, which is what we're targeting for our vaccines. So that's why we have to know this information. The animal model, we had that up and developed by, I've lost track of time, I'm sorry, but certainly within about 3 to 4 weeks, we demonstrated our model was valid. Again, first in world to demonstrate a animal model to do preclinical testing. We're still going on looking at what's happening to those animals to understand this. I know the Doherty's looking at what's happening with humans as the infection infects them. We're now testing 2 candidates. One's from Oxford and one's from the US, the Inovio. One's a DNA recombinant, and the other one is an adenovirus attenuated platform. That one we're testing on intranasal and intramuscular. The other one's on a more like an electrophoretic injection that's rather complex. That's the Inovio. And the animals have been vaccinated and will be challenged next week. And we will watch them over the next period. That study will be finished by June. We're now already starting to plan for the next candidates, which we'll take in July. So there's about 70 candidates globally now. CEPI, who's funding this work for us, has got around about 6 or 7. So they'll be leading another few towards us for testing in July. The bottom part here is what's been happening with the University of Queensland one. Now that was a mathematical model until our team at Clayton turned it into a real protein. And that's going through a phase of adding what adjuvants need to be added to the vaccine. Now, adjuvants are stimulants of your immune system. So you give the protein with an adjuvant and that stimulates your immune system to actually make it work. They should be starting preclinical testing in the next month or so, which is exciting to news. Now, you would have seen in the press, Oxford, one of the candidates, is going to start phase 1 human trials at the end of this month. That's scary. Moderna's already started phase 1 human trials. That's scary as well. So why am I scared? I guess we do the animal studies because we're looking for safety and efficacy, and then we move on to the preclinicals. Now, phase 1 is really looking at safety in humans. So because this pandemic is such a crisis, and because the Oxford is on a standard and the Johnson & Johnson are both on adenovirus media, the regulators feel comfortable for phase 1 to start, but they won't move to phase 2 until the animal trials are through. And the Oxford is also doing a sister animal trial in another country on non-human primates. So they've got the two, which will actually have the 2 animal rule to allow it to go through FDA approval. So people are thinking of, how do we start the human trials? How do we actually get through regulators? And then how do we actually make enough? So I know that Oxford just signed a deal with Merck to look at mass production of this. I know that other companies like Johnson & Johnson are involved, in CSL's certainly talking with University of Queensland, if theirs works, to actually produce industrial quantities for us to use. So everything's happening so fast and so fast together, and with such cooperation that has never been seen in this area of work, because the competition is generally corporate held together. So thinking about where it is, the hardest parts here are obviously phase 1 to 2 to 3. We may find that we'll go into, in fact, actually a quasi phase 3, more broader market with post-market surveillance. It's hard to say what regulators are going to be doing in this stage. And then there's the idea of actually producing enough, and this is the ethical discussion that I know Daryl and myself we've been in discussions about our neighbours here, because this is the thing that worries us, who's going to get it and who's not going to get it. In fact, the federal government's got me on a committee looking at how we're going to get it in Australia. So we're doing the research. We're not guaranteed we're going to get the finished result here either, so park that one too. So the research and development pathway, just to run rapidly through this, I've talked at length about vaccine. The diagnostics I've talked about, these are the ways that are going to shape the future for us, because as we move close to suppression, we're going to need to test just about everyone. And so some of the new normal I've sort of been toying with is, for us to return to work, we're going to need to have the idea of, are you clear? Are you clear to go home to work? And also, in a lot of settings, are we able to work together? So there's a lot of close settings. So you can imagine, even just for national security, that our military is, this is a crucial challenge for them. You're on a ship, you're on a submarine. Are you fit to actually defend the country in that setting? But more so even for workers, as we move into the idea of where are the cases. The other one will be, we need to find cases when they come out. So a future cycle may be GPs in primary settings will be testing everyone with upper respiratory tract symptoms of fevers. Have they or have they not got it? And then if we find cases, to in fact actually try to quarantine those areas. So we may find that certain postcodes and others may be quarantined for 2 weeks when we find it, as we move into the future. Drugs, the amount of work going on there, we may find some that modulate the severity of the disease. That's probably the most likely, but we may find some that in fact actually do decrease the period of infectivity. But that's, as you know, with antivirals, for many of you have probably been on personal journeys and also professional journeys of the HIV area, of how long it's taken us to get where we are with the drugs and the challenges we've had. Analytics, you saw Damien's presentation there. Protective gear, this is the beauty.
Yep. Just conscious of time, so if you could wander us through the last few slides quickly.
No trouble. I think that's actually about it, to be honest with you.
Okay. Do you want to finish off that slide?
Yeah, I'll finish off that one. That was the last one. Go back to that. It's very self-centered. So protective gear is really looking at new masks and new other gear that we actually do need, because our health workers are dreadfully exposed. The sterilisation is an interesting one, and this one, Daryl, you were sort of elucidating about the environmental persistence of the virus and how do we manage it. The good thing is soap is fantastic. Soap gets rid of human mucus and protein, so soapy water is the best thing you can do. So Grandma was right. That'll break it down. The next thing is to in fact actually clean things with a dilute bleach solution or an alcohol solution, and that works. That's all you need to do. There's a lot of fancy work going on here. I've seen so much stuff in science in this area where people have come from other areas to say, hey, we can solve your problems with UV rays and all sorts of stuff. I was on a working group with one of the big airline manufacturers looking at how we might clean planes to reinstate airline travel and things like this. So I have to say, Grandma's right. Soap and water, still the best, and you bleach your alcohol solutions. Preventive health is another one that we've got to look at, right? And I was thinking of the parallels asked about this one, Daryl, with regards to what we've done with HIV, that people get other diseases as well, right? one, we've given everyone the most stress they'll probably ever have in their whole life. We've locked them in the house. Some people they love and some people they hate. So that we've created some difficult situations for a lot of people. We've also the idea of how do I eat healthy? How do I actually maintain physical fitness? And how do I actually look at my mental well-being? So CSIRO's got a long history in nutrition areas, and we've been working with South Australian Health Department on getting some things up, which will be launched very soon on some of the health that's actually required here. And the next one is planning for the future, which really looks something like this. We really could have done a lot more of this, prevention, awareness and protection. We really can do a lot more detection within the response phase, but no one does any work in recovery, right? And again, I think this is where I'd look to the HIV sector as the example of how do we recover from the decimation that occurred through the 80s, and how do we actually, use what we learned there of actually rebuilding our societies into how we should behave, how we should relate to each other, and how things should move on. So I'll stop there. And
Well, thank you so much, and appreciate we've just covered both in your presentation and Damien's just an incredible breadth of work. What I want to do, we've got about 12 minutes remaining. I just want to do something a little bit, probably a bit tough on you, Damien and Rob, which is just to do a couple of really rapid fire questions first, really quick responses just on some of the things that are technical. So we've got a bit of time for discussion. Rob, can we pin you on your claim, your assertion that this is definitely coming from animals? There's talk about maybe this being something from a lab somewhere. How certain are we that this is actually jumped to humans from animals?
Look, with almost a high degree of certainty about the lineage of the virus and the understanding of the virus. So I had the pleasure of a bat scientist as being one of my staff who's also worked closely with the scientists in Wuhan, which is actually the Center for Virology in China. So they are internationally regarded experts. They did not create this virus. They just found it. It's a bit like if you happen to work in a place that understands something, you're the ones that will find it because you're looking for it, which is really what happened in Wuhan.
That's great. Thank you. Another quick question. Reactivation, is this possible? So when we talk about recovery from COVID-19, are we talking cure for people who have had it and are now better? Are they cured, or is there some possibility that they still have the prospects for reactivation?
We don't have an answer to that. Off you go, Damien.
Oh, no, I think in short, that's the correct answer. I was going to add as well that I think something, just to sort of explain some of the confusion, I think there's difficulty with the test. So one of them is, PCR, which is the testing that we're doing now, which basically looks for bits of viral DNA or RNA, I should say, so genetic material in the nasopharynx. We don't have serology, or it's not widespread. So that's seeing, on your antibodies in your blood, whether you've definitely been exposed to this virus or not. So you can't pick up the asymptomatics. One of the issues with this, I had a read of the case reports of the reinfections just this morning. One of the issues is you can't, with that PCR swab, distinguish whether there's live active virus in someone or whether you're picking up traces of DNA or RNA, from the virus that they've already cleared, but there's still some traces there. The other thing is it's very hard to know whether they in fact cleared it and then re-got it versus just always had it and a prolonged shedders, but one of your tests along the way was just incorrectly negative. So there's a lot of unknowns, but the short answer is don't know.
Thank you. Let's go to the question of testing and of asymptomatic transmission or asymptomatic infection. How can we be confident in Australia that we don't have, so we're watching the case numbers drop to single digit numbers in most states, most days. How do we know that there's not large numbers of people in the community with COVID-19 who simply haven't been detected?
What we see is, I guess the one thing there is we see pop-ups. So Western Sydney is an example of a pop-up, so to speak. So the health worker contracted it from somewhere. I haven't actually looked at the case as to where they got it, but then they spread it to the people in the nursing home. So you have to give it to someone who's going to get symptomatic and actually get severely ill, which is how you would actually find that you've got a outbreak. So it's unlikely that we've got many people out there that are asymptomatic, because they would still be giving it to people who would be getting symptomatic, and we'd see them at hospitals. What do you reckon, Damien?
I'm certainly not an expert on it, but I've heard lots of different opinions. I know the Victorian Chief Health Officer said last week that he suspects that the actual case numbers could be 5 to 10 times higher in terms of the asymptomatic burden. But I think that the serology testing is going to be the key in delineating that. So actually being able to not just test symptomatic people or people that you suspect may be exposed, but just to test a wide proportion of the community. Just as a small footnote, there's a recently published study that I think it's widely accessible, but Iceland did a community survey, and essentially they did random testing, and they also did open invitation testing. So people who wanted to get tested, these are asymptomatic people, and then they just did a random proportion of the population. And I think the rate was about 0.6 to 1% of the population, just as a sort of a cross-sectional survey, were positive.
Thank you. Let's go to therapeutics. We're seeing some media pickup of remdesivir and its effectiveness in acutely unwell patients, seriously unwell patients. How hopeful should we be that it offers prospects for an effective treatment?
So the experience we got from China was some published papers early on in the piece that talked about clinical courses and what they'd actually tried to do. And I've been quoted as saying they tried just about everything, which I'm sure they did. There seemed to be some poorly constructed studies, but we've now got the study that's being coordinated by the German Infectious Diseases Centre with regards to actually global study of looking at trying to do this properly. In the sense of looking at how drugs work. So what I would say is the jury's still out on whether these drugs actually affect or assist in the management. I don't know, Damien, whether you've got anything else to add on that?
No, I agree entirely. I've heard the same, that the data out so far, the studies are small numbers, not very robust so far. There's not compelling evidence yet.
And then in terms of evidence building and in terms of the pace at which we're learning, but also we're needing to respond. You made a comment earlier on, Rob, about some of the, I think your term was the outlandish claims, and you were talking specifically about vaccines there. And I was really struck, if we're talking about vaccine development, normally a 10 to 20 year process. If we're talking about therapeutics, phase 1 to phase 4 trials, a 7-year process. What realistically, even in this environment, can we expect in terms of the timeframes for something to be available for COVID-19, whether it's a therapeutic or a vaccine?
So we'll have the preliminary animal data on the 2 samples we're looking at, and there'll be others that will be available coming up over the next couple of months. That's going to be exciting because that's fast to get to this point. The other one is by starting those phase 1 trials early, which of course is a risk. But they are with established platforms, so that's a little reassuring. But the reason we didn't get a SARS vaccine was it caused more harm than good. It actually primed the immune systems of the animals that they were given to, so it never went to human. So that's the thing that actually burns in particularly my scientists' mind about the haste. Realistically, let's say the Oxford one on an adenovirus medium works. They're doing their phase 1 starting in around a little less than a month or a few weeks. Ours comes through, we start to see the results, and then they move to phase 2. We may find the availability of a readily produced vaccine in about the end of the year, into the new year. That would be incredible for that to occur. For a new type of structure like the University of Queensland, this is wild for something like that to get into human use, because it's got to go through a lot of safety things, because this has never been used as a platform on humans. So that's a big call. And a lot of the ones, if you look at the Oxford site, you'll see there's the 70 candidates that are available. You'll see that a lot of those are in fact actually really bold experimental claims. So the total optimist view is by New Year we'll get a present.
Wow. Okay. So let's thank you. Let's move from the science and prospects for a vaccine or for a treatment. Let's move to what we do in the interim. Let's move to the public health side of things, and just going back to the modelling, Damien. So the model you presented showed us how various strategies, patient isolation, quarantine of contacts, and physical distancing, how those 3 things come together to flatten the curve in Australia. and that keeps capacity within our hospitals adequate to manage patient load. How does that strategy, how is that different to building herd immunity or to eradication? Because we're hearing about both of those things, and yet my reading of the model you've presented is that it's neither of those things, it's something different again. Can you walk us through what the different options are and where your modelling fits into that? But also, is eradication a possibility in Australia?
Yeah, so there's a lot to unpack there. So look, in short, I think the next stage or the next step now with our modelling is to become more granular. So this was really an overview looking at Australia as a whole and the initial, the potential initial situation. What we're looking now at is refining the modelling so that you can tell, smaller areas and more smaller time frames, actually what's happening. And I think just to use some sort of cliches or metaphors that have been thrown around, but I think they're quite helpful. One is, we're kind of in a lifeboat now. The question is where and how we steer that. So look, again, I haven't sat in any meeting where any experts, and I'm surrounded by experts, I wouldn't claim to be one, but I'm yet to sit in a meeting where anyone claims to have the answer. But I think a combination of things. One is, if we consider that a vaccine is the end point, that, the light at the end of the tunnel that'll get us all out of trouble, while we're sort of puddling along to that phase, I think another phrase I heard was, it's a game of whack-a-mole. So basically, as the healthcare capacity catches up, the testing capacity ramps up, we set up sentinel testing. So like these pop-up clinics that Rob mentioned. So we're not just testing people with fevers and symptoms, we're testing more widely so we can identify cases earlier. As the capacity increases, we can slowly kind of ease restrictions. But it's not going to be life as it was 2-3 months ago until that endpoint. But in the meantime, things will slowly get eased, ideally. Certainly, hopefully in about 4 weeks, we can start doing that. And that's when the really increased surveillance is going to be critical to identifying cases early and sort of having smaller lockdowns for smaller periods of time. So a suburb or a postcode as opposed to, the entire country. And just sort of on a positive note, just a few bits of technology I know the Doherty are working on that really help facilitate this. One is genetic typing of the virus, which is, I find fascinating, that already on positive samples in Melbourne, they can look at that and tell if someone got it from a colleague at work or from the party or from the Ruby Princess. And that helps with contact tracing. It takes a lot of the guesswork out of it and it makes these predictions more refined. The other thing is wastewater surveillance, that you can get tiny fragments of the virus's, genetic material from wastewater sewage systems and potentially pick up outbreaks or clusters before people are even presenting to health services. And that'll all feed towards, the sort of whack-a-mole scenario of we just find these clusters and bear down on them quickly. But until there's a vaccine, it's going to be a lot of trade-offs.
Mm-hmm.
Rob, any comments on that?
I totally agree. The new world is nothing like we've done. So the idea about international air travel, that's extremely unlikely for the next 2 years without a vaccine. One, because you've got to have to find a country that's going to accept the plane. Two, you're probably going to find you'll be quarantined for 2 weeks when you land in another country and definitely when you return to Australia. So that's actually sad. So domestic travel is going to do well from Australians, but we might actually still, again, as Damien said, as we get clusters breaking out, you might find you can't go to certain areas because they've been closed down because they're under control. This is really going to be a different world.
Thank you. Can I try a bit of a summary of that? And I just want to test that with you both, just to see whether my takeout from what you've presented is reasonable, and you can argue and change and adjust and add to it. But I think what I'm taking away is we've got here in Australia, and including through the work of the Doherty and the CSIRO, we've got the very best of the world's scientists focused on this problem in terms of a vaccine, in terms of therapeutics, and in terms of diagnostics. We've got that work moving at breakneck speed with all effort to get that moving as quickly as possible. but realistically it will take time. There's no version of any of those outcomes, particularly in the vaccine and the therapeutic side, that is measured in weeks, and even on the most optimistic, not in months either. So we have a journey before we get to a place where we've got effective therapeutics and effective vaccine. And in the interim, what we've got are the kind of measures that you've presented, Damien, in terms of continued isolation of those who acquire COVID-19, management of their contacts, and then this sort of adjustment of social distancing, which we're all living with. We're all sitting in our lounge rooms, in our studies, trying to flatten the curve. And so our main lever in the period while we're waiting for those therapeutics and vaccines to come online is to manage that social distancing so that our hospitals, our healthcare workers, and are not overwhelmed by the burden. Is that kind of the summary of what this looks like? And that's not a thing to be measured in months. It's a thing to be measured certainly for the rest of 2020 and into 2021. Query how far into that year, if not to the end of that year. And for international travel, who knows? But until there's a cure, until there's an effective vaccine, that doesn't look likely. Is that kind of a reasonable takeout from what you've told us?
Yeah, absolutely. I mean, like the other one I just want to point out is I'm deeply concerned about some marginalised communities in Australia, particularly the remote Aboriginal communities, and I share that with Aboriginal leaders I've been working with. And the other one, Darryl, that we've been talking about regionally for the Pacific Islands, is the other one that is the thing that keeps us awake at night as to how are we actually going to help and assist with this one. These are, yes, we can sort out Australia. We will lose a lot of Australians, but hopefully not as many as Americans are going to be lost. But gosh, the regions are scary.
I think that's actually a really sobering note, but the right note in terms of our values and our role, not only domestically, but actually as leaders internationally. It's a great note for us to end on. Damien, any final comments from you as well?
No, thank you, Rob, for that comment as well about regional partners. I know that Jody McVernon at the Doherty is collaborating with DFAT and Ministry of Health in Papua New Guinea, definitely trying to sort of provide solutions or some assistance really to these exact problems. And we're doing a lot of work as well with remote communities in terms of testing strategies. And no, I guess the only thing I wanted to say, I know there's a lot of unanswered questions and people have probably got a lot more. Just a reminder, not to plug either Q&A or the Doherty too much, but Jody McVernon will be on Q&A, and these are exactly the questions she's going to be addressing as well. And she's really got a finger on the pulse.
That's great. So let's stay tuned for that tonight on the ABC. The other thing is I'm going to hit Rob and Damien up after this call. We've got some really fantastic comments coming through and questions coming through in the chat. We haven't been able to respond to them all, but I'll follow up. We'll follow up separately with Damien and Rob to see if we can get some more answers to those, and we'll share them through the FAO website. So please keep your eye on our landing page for both this webinar, but also a response to the chat. Rob and Damien, thank you so much for joining us today. Thank you everyone for being part of this call. Great to have you online.
Thank you. Thank you for having us.
Bye-bye.
Thank you.